but you have the option of having two that go in the two holes that he wants to, so you can just do it at the same time.
Do two holes at the same time. Okay.
So with it, if he's gone to say 17 for the flexible reamer, then we're going to go 17 with a transition reamer.
Show us how flexible it is.
They're quite flexible.
Yeah.
That's what you start with to just prepare the start of the hole.
So that's just to literally just score the cortex. I'm just going to score the cortex. I'm going to take that one out, and then we're going to drill the lateral cortex. Okay? So that would go, the bone would go till there. You see? So we're just going to pass the lateral cortex through that. Then you need to put this one back in again. Because
see how thin this one is compared to the other two.
Because it's the guide.
This one we're going to send all the way through. Okay. Now the recommendation is to leave that as it is, because it is our only form of anchorage at the moment. This is the level of the GT. It's going very shallow into the femur, and the purpose of it is to just be able to make space for that widened bit at the top of the actual implant. Should have on the shelf elsewhere is a ball tip guide wire for this procedure.
Yes.
Yes. So you would need one of those for the flexible reamers.
Is there a specific size that we need, or?
It's on that guide. It's on the guide.
So what do we have here? Is it okay, or?
I'm sure it'll be, because they'll use it before.
And how long does it need to be? Because we have different lengths.
Call it, this is what needs to go in.
Okay. Oh, so 600 might be okay, isn't it?
Yeah, as long as it can go all the way in, he can hold it and pass that over easily.
And starting with the trays that you need to open, they've decided we're going ILS. Not likely, but they've decided. Definitely.
This abbreviation stand for?
ILS is interlocking stem.
Or interlocking stand.
So we're going to put screws in because using the...
So, instruments-wise?
Instruments, basically all of them.
Even this one.
Pop that one back under again,
So
we don't
these
need that.
150 and 190 reamers STS gone. We're not using it for.
Interlocking stand.
So we're back to our general instruments, cone bodies, flexible reamers.
What do you call these general instruments again? Like what? Blank general instruments. Just Arcos general instruments.
So flexible reamers.
The transitional.
So your transitional porous distal reamers.
These all come in this tray.
No, this
That,
is for total
that,
hip.
and that.
Sorry?
Total hip or
It's
Revision.
still revision. Again, this is all Arcos.
Oh, okay.
This is just for simpler cases. These are for more complicated cases where they need to go.
Yeah, you put interlocking screws into the femur. The porous distal transition reamers, and these are the transition trowels. But I've actually never seen these being used. Just the normal trowels are used. And then a set of heads, obviously, which we're not going to worry about.
Okay. So it's 4 extra trays. We'll start with you need a guide wire.
Yeah, bolted guide wire.
These ones start from 14. So that one started from 12. This one starts from 14 and goes up in 0.5. They might just go up in 0.5 or go up in 1 increments.
Show us how flexible it is.
They're quite flexible.
Yeah.
The surgeon will go with the flexible reamers until he's happy. So these are obviously going to go on to power. We're not going to do.
Yeah.
This is obviously power. And then when he's happy with the results that he's wanting, we will then move on to preparing the rest of the femur. So the transitional reamers, They're literally just reamers that will also go onto power. What it is the actual implant. If you look at it, it flares a little bit at the top, right? See, it's curved, and it has a little bit of a flare at the top. I don't know if I think the implant itself may flare a bit more than the trowel does. And for that, we therefore need to have these reamers. So it's the distal. If you look, it's called the porous distal transition reamers. So we're basically just going to, if you look at, this is the level of the GT. It's going very shallow into the femur. And the purpose of it is to just be able to make space for that widened bit at the top of the actual implant. Okay?
He's used this to prepare for the bottom. Some
Yeah.
to prepare for the bottom, and then use that to prepare for
The top. So if he's gone to say 17 for the flexible reamer, then we're going to go 17 with a transition reamer. Then we have to go on to preparing the screw holes that we're going to put at the bottom. In this tray, we have the arms that we use. Okay,
coming right and left.
so got a right side, left side,
Where do you see the right? I mean, where the
right hand.
right? Okay.
Yeah. So just so
Yeah.
Okay.
Right side, left side, depending on which leg we're doing. Obviously, that's just an impactor for once we've lined up the implant. We're going to do a couple little tests to make sure we line up the implant right, and then you'll just give him that, and he's going to then whack it in. Okay. Take this off. Don't leave this on, because if you feel it, it's rather heavy. And what's very important is we don't want them leaning on this once it's in, because it's going to move.
I wouldn't worry about knowing how to fix this on, because most surgeons will, because it has you can see it has a bend. The bend needs to match the implant, so surgeons will most likely do this themselves.
Can go around any, like it
It
can.
can go anywhere. but
Okay,
it needs
yeah,
to
yeah.
be a
So if you see that the cone body have the little tabs on, this one's also got the little tabs on. Okay, so we need to make sure that it's lined up properly. Then the next thing we're going to do is make sure that, so the actual stem, now we don't have an actual stem, obviously, we can't open up. The actual stem will have the screw holes in it. And what is important for us to do is to make sure that these holes line up with the actual
Screw holes.
the actual screw holes for the actual implant.
And
Okay.
we just use any wire, or
No.
do we have a?
We'll get there.
Is it this one?
So we got two parts, right?
This is something you can put together early on. I'll just say, in terms of steps, because there's 3 steps to this
Yes.
that they follow. So these 2 pieces.
So this is for the screw itself.
Yeah.
This is for the drill.
Yes.
Okay.
Exactly. So just having the bits out, because it can be confusing. If you have, you have those 2 bits out, and having these as well. All of this comes in straight. It can be quite confusing. So we're just going to explain that this bit very well, because it can be a bit confusing.
So if you look here, you'll see we've got 200, 250, and 300. Those are the 3 different size stems we've got. Okay. And what we're wanting to do is to put at least 2 screws in. And one must be at the distal part of the implant. Obviously, there's more options for the 300 than there are for the 200. There's only 2 for the 200. So the 200 will only have 2 screw holes in it, but the 250 and the 300 would have 3 screw holes in it. Then he can choose which screw holes does he want to put in. Does he want to put 3 in? Does he only want to put 2 in? Which 2 does he want to put in? He must put 1 at the end, but he can put in any of these other ones. It'll obviously depend on where the fracture line is. You will use this little device to see, does it, you see. So if you see, we've got, the arm has got a bend to it, it will have a bend to it, and then you put this through, and this little end should go through the hole if it's properly lined up. So that's the way we test to make sure that we've lined it up properly.
Because multiple screws can go in, you can have a surgeon that will just use one of these and do his to prepare for his screw, but you have the option of having 2 that go in the 2 holes that he wants to, so you can just do it at the same time.
Do 2 holes at the same time. Okay.
So with the 3 drills, right, so the one is One is to score the cortex. The other one is to go through the lateral side of the cortex. And the other one is to go through to the medial side of the cortex. When it gets knocked in, the implant will go down the femur, and this will be on the outside of the leg. Okay. Right. And then most surgeons would obviously make little holes in the skin, but you don't actually need to be able to see all the way through. So you're not going to be opening up the hole. It will be literally like, so the surgeon will put one little stitch and one little stitch to close it up later. And that's why it's so important that we must line it up properly, because we're not going to have this marvelous open view of the screw holes. And that's why we obviously use the drill guides as well. The first thing we're going to do is to prepare the most distal. So it's very important that you're very gentle with this, because we don't want the things moving. Okay. So first you're going to do is you're going to just,
you can see the ends. Just make note of how the ends look. This is the first one. It's just the shortest. Let's say you're going up in height. Actually, if you look, you're going up in height. So that's the shortest bit. That's what you start with to just prepare the start of the hole.
so that's just to literally just score the cortex. Okay, I'm just going to score the cortex. I'm going to take that one out, and then we're going to drill the lateral cortex. Okay, so that would go, the bone would go till there. You see, so we're just going to pass the lateral cortex through that. Then you need to put this one back in again, because
see how thin this one is compared
one
to
is-
the other two.
Because it's the guide.
this
the drill
one
guide.
we're going to send all the way through. Okay. Now the recommendation is to leave that as it is, because it is our only form of anchorage at the moment. If you're going to take that all out and then do the second hole, you may move, something may move, and then we may not find that first hole again. So leave that in like that, right? And then we start again with the second one. We've got three
So
of
yes,
everything,
so-
you see.
Okay.
Oh, not
You-
three,
you've
two.
got one of this, the starter one.
You've got two of those and three
and
of
three
these.
of these. So don't
Okay.
get complete. Don't be like, oh, which one is it?
And we've got
There's
two
three
of
of
these as well. Next one again. You score, right? Lateral cortex. Drill guide in. Medial cortex. Okay. So now we've got two holes, right? Now we're going to put the first screw in this one. Okay. And the screws come individually packed, so we don't really have any screws.
Do we measure?
Imagine the screw. Yes.
Yes, there's a there. So we would measure, right? So that needs to go through the hole, and it needs to grip on the medial cortex, right? And then, so this moves back and forward there. You see, so if it grips on the medial cortex over there, that would be a 32.
Does it need to be
25,
all the way?
25, 40,
Like,
Oh, okay.
does it need to be here all the? Oh no, you said here. It should just.
So you're
fine.
going to push it all the way in,
there.
right? And then you're going to pull that back.
Okay.
You see,
Okay.
and we want this to hook on the lateral cortex, so outside the bone. Okay. The recommendation also is, if it might be a 30 or it might end up being a 31, go for the 32. Okay. Because you don't want it to be too short, you want it to be longer, so rather longer than shorter. Then that will come out, and the screw will go in, and there's your screwdriver. And you're going to screw the first screw in. Okay. And so far we've left that first distal hole in place. Okay. So once we've got that screw in place, then we can then move on to the next screw. Yeah, you're right.
To measure it.
Yeah, to know what screw
It's on the
size.
drill already.
No.
So you just pass that through, and then you pull that back.
So after that, we'll take it off.
So then, yeah.
Yeah.
So then there's a. Trying to remember now. So this needs to come with the
Implant.
implant.
Is this the attachment for it?
Yes, that is the attachment point. So that would go down like that, right? To attach, and then that goes over, right? You see how little I use this stuff, and then that to unscrew it, we would just use the T-handle. Okay, unscrew it off the arm, and then the arm would just be loose because this isn't going to go inside.
Then we're gonna go to that
So then after that you would do the same thing again. The implant is in. You go. So the surgeon might just put this in by hand. Then I would think would probably be the best thing. Put that in by hand. Cone bodies like we did
Reaming,
earlier on.
yes.
Same thing. It's the same. And then take this off with a little screwdriver. Trowel, and off you go. Okay, and so from this part, it's the same as with the SC.
what we did.